Good morning, everyone. Shall I start, sir? Shall I start, sir?
Rahul, good morning. Please start.
Morning, sir. So today's topic will be on BMAC, PRP, and ACI. Starting off with BMAC, it is an optimal molecular concentration of both stem cells and growth factors. So the growth factors in BMAC are PDGF, TGF beta, BMP2 and 7, and interleukin-1 receptor antagonist. And these growth factors have synergistic effect in an anabolic mechanism and also anti-inflammatory effects. So there is a lot of controversy regarding harvesting BMAC, and various literature describes the technique in a different way. This is a standardized technique which was published by Patellar, and he harvested 1 ml of heparin BMAC, approximately 60 ml of bone marrow, and he used 230 ml syringes for this. The whole processing is a bit complex. He filters the bone marrow aspirate in a 200 micrometer mesh filter in a 50 ml conical tube. And this 50 ml conical tube gets into centrifuge of 3400 RPM for 6 minutes. And this total of 60 ml of bone marrow aspirate gets converted into 60 ml BMAC. It's an aspirate concentrate. So this BMAC gets analyzed before it gets used for target tissue. So before target use, it can be activated by using an enzyme called batroxobin. So this is an article by Casano et al. In Casta 2018. He found that the interleukin-1 receptor antagonist concentration were greater in BMAC samples rather than in PRP, as so much so as it's more than double the concentration. And he found that this interleukin-1 receptor antagonist is probably the most contributing factor in exhibiting the effects of BMAC. So technically, it is easy to harvest. The sites of harvest are the iliac crest, the proximal tibia, or the distal femur, or even in the intercondylar notch. And there is no cultural expansion, and there's no risk of any allergenic disease transmission. And there's a very low risk of infection. And it can be also performed with concomitant procedures. So main disadvantages being potential pain during harvest and variable quantity of stem cell that can be harvested depending on the site and age of the patient who's it being harvested from. And it has some potential detrimental effects of RBCs, which inside the joint can cause some reactions. So regarding the mechanism of these mesenchymal stem cells in BMAC, there is one item of consideration that these mesenchymal stem cells can further divide into oncogenic cell lineages. Otherwise, it is very safe. So these are a few studies which shows BMAC to be useful in most of the focal cartilage defects, and it has reported good outcomes. And these low two articles describe the role of BMAC in osteoarthritis. So it has performed better when it is compared with viscosupplements like hyaluronic acid. So there is lack of clear consensus regarding the use of a scaffold or an augmentation with BMAC injection. But there are studies even without these scaffolds where BMAC is used isolatedly was able to give good results. So here's a picture showing these BMAC. This is the site of interest, and this is the BMAC after activation. Gets dispersed onto the site and gets stuck onto the site by a fibrin loop. So here are some of the studies of BMAC used for cartilage diseases. Gobi et al. Has been studying a lot of this BMAC, and he has found that in most of his studies, the in final follow-up, the patient has reported significant improvement in the patient-reported outcome scores. And two of his studies, a 24-month follow-up and a 3-year follow-up, he found that the complete defect was completely filled on final follow-up MRI, almost in 80%, 80% of the defect being filled. And this NEA et al. In 2015, in his 9-patient case series, he found that there was one failure rate, and the patient had to undergo a successive surgery. And most of the patients were asymptomatic, and 4 were classified as near normal ICRS grade at final follow-up. This is again Gobi et al. Study. He's been working on this for quite some long time, and all his results are similar. This is a 2016 study where he found that even age more than 45 years and larger lesion size and multiple lesions, they were not associated with any inferior outcome, which was the case in case of BMAC with hyaluronic acid group. So this is another article by Heed et al. Where he studied 10 patients with a mean age of 29 years. These patients had full thickness cartilage defects, and they were treated with BMAC with PRP. It was a one-step procedure. Both BMAC and PRP were seeded onto the collagen scaffold, and it was, as you can see in this illustration, it was sutured to the defect. And second look arthroscopy were performed, and they also did a biopsy and also a histomorphometry. And they found that the mixture of fibrous tissue and fibrous cartilage, 58 and 40% respectively, was found. And they told that the quality of the healing of this BMAC with PRP is not exactly hyaline, and it's below par. And this is one article where they did not vouch for this BMAC. They found that all the studies were of not good quality, and there were some animal studies which found which had questionable evidence whether BMAC works in these cartilage defects. So they had recommended that clinical applications of this BMAC can be inconsistent. This is again BMAC in osteoarthritis, where Hauser and Orlowski they reported good functional outcome scores after 2 injections of BMAC at 2 to 3 month intervals. So they recommend 2 to 6 injections over a period of 3 months for osteoarthritis. And patients with lesions who had significant improvement have Kelgel tolerance grade 2 than patients with advanced OA. Coming to ACI, ACI was first done by Dr. Lars Peterson back in 1987. His first cohort of cases, where he also confirmed with the second look biopsies, found ACIs to be useful in cartilage defects. So this is the first generation ACI. So in this first generation ACI, they use a periosteal tissue harvest, and it gets sewed onto the defect and a watertight closure mechanism to avoid spillage of the chondrocytes. So, and there is no scaffold being used, and it is a 2-stage procedure. And since it's been there for a long time, there are enough studies to document its efficacy. So these are the two brand names it comes in. So Carticel and Chondroglide. So the main drawback of the first generation was the mobility of the harvest site, the periosteum being harvested, and usually it is in the proximal tibia. And these periosteal pads over a period of time can tend to hypertrophy and delaminate. So this was first documented by Gooding et al. Back in 2005. This is the second generation ACI, where there is a scaffold of hydrogel or a fibrous scaffold or a decellularized extracellular matrix with this autologous chondrocytes. So these chondrocytes are expanded and seeded ex vivo, and it gets incorporated at the cartilage defects. So this is also called as matrix-induced autologous chondrocyte implantation, called MACI. So coming to scaffolds, it's mainly hydrogel or membranes, and each of these hydrogels or membranes can be either natural or synthetic. Natural, the most common being hyaluronic acid and chondroitin sulfate. And among the membranes, the natural entities being periosteal flap and collagen membranes. Synthetic are coming up in recent times, and there is evidence that polyvinyl alcohol and polyethylene glycol dicrylate, these synthetic hydrogels, polymers, along with hyaluronic acid with fibrin glue are phase 3 trials and supposed to have very good outcomes. Collagen hydrogels produced from type 1 and type 2 collagen, they tend to initiate the chondrogenesis, and type 2 collagen, along with enhancing and promotes differentiation of the mesenchymal stem cells into chondrogenic lineage. Fibrin, when it's used along with its activated thrombin, it minimizes any transmission risk and also acts as an effective carrier for securing the cartilage chondrocytes into the defect. So MACI is a composite of polylactic acid and copolymer of glycolic acid and polydioxazone. So this is the membrane that gets infiltrated with fibrin. And DEPU has this own ACI, this CAIS. It's a copolymer membrane where they use 35% of polycaprolactone and 65% of polyglycolic acid reinforced with polydioxazone mesh. So this is an article in AJSM 2010 where they compared this ACI using periosteum cover, first generation and basically second generation MACI and the periosteum one. And they found that there was no significant difference in efficacy between either of them. And coming to the third generation, along with the allogenic, along with the chondrocytes, they use these integrated growth factors with the stem cells into the matrix. So apart from that, everything else from the second generation is similar. And these are the brand names: De Novo, ET, and NT. They come in pre-tailored sizes. And so this particular one is 25 centimeters square for a defect of 25 centimeters square. So this is one article where they had described about the failure rates of each of these generations of ACI. As you can see, the first generation ACI had more of hypertrophy of the graft, delamination, and arthrofibrosis compared to the third generation. And the picture that you see, this 25% is because of the number of cases of third generation ACI that was included in the whole analysis. So it was only 8, and only one of the 8 had delamination, and hence the 25% increase. Otherwise, with increasing generation, the complications decreased. So this is Beckers et al. In his article. He found that chondrocytes along with mesenchymal stem cells, when used along with, increases the cartilage matrix production and helps in upregulation of cartilage-specific genes. So here you can see the microstructure of chondron, where chondrocyte, it includes the chondrocyte and the pedicellular matrix. This chondron along with the mesenchymal stem cells will cause increased cartilage matrix formation. So regarding the maturity of ACI, so implantation is from 0 to 6 weeks. And here in this first phase is the chondrocytes and the extracellular matrix is not yet formed. And second phase is from 6 to 12 weeks. It's a transition of proliferation stage, and there is primitive repair tissue that's being formed. And in the early maturation phase, it becomes, it solidifies, and matrix consists of collagen, aggregates, and other matrix proteins. And after 26 weeks to 3 years, there is late maturation stage. And at full maturity, it gets as strong as it can. And after full maturity, patient is advised to return to sports. So these ACI, when being harvested, one vial can contain of approximately 12 million cells. And this one vial is, this 12 million cells is sufficient to treat defect of up to 7 centimeters square. Coming to the postoperative rehab in ACI, the patient is immobilized for 6 to 12 hours to allow settling of the cells to adhere on the subchondral bone. And the first 6 weeks will be non-weight bearing phase, and 6 to 12 weeks will be functional activities like low impact exercises like stationary bicycling and treadmill walking. And patient can avoid, after 6 months, patient can do most of his activity other than compact sports. So compact sports and high impact sports to be done only after 12 to 18 months. So the main indications of ACI is between 15 to 55 years, certainly the younger age group, and a patient who have a desire to return to sports on high impact activities and willing to undergo a longer rehab protocol, and lesion size being 2 to 12 centimeters square, a bone loss of more than 6 minimum in depth. This generally precludes the use of traditional ACI, although there can be staged where bone grafting can also be done and reduce the amount of bone loss, and then again the second stage ACI can be done. And previous failed microfracture surgeries or other cartilage procedures, and symptomatic grade 3 to 4 lesions of femoral condylar trochlea. Patients with kissing lesions of the femur are not good candidates for ACI, and patients with pre-existing malalignment or instability are again not good candidates. So this article says that the ideal candidate will be a younger patient with a shorter duration of symptoms, the single defect located in either in the trochlea or the lateral femoral condyle, or those with 2 previous procedures of the index finger. So it's basically contraindicated in deep subcondylar bone involvement and poor patient compliance where they cannot adhere to the post-op protocol, and high BMI patients more than 35 kilogram per meter square, and more than 50% of the joint space narrowing, and inflammatory arthropathy, tobacco abuse, and again malalignment and instability patients. So basically, the surgical steps in ACI is chondrocyte harvest, and graft gets implanted at the periosteal patch in case of first generation, and the defect gets prepared, and then the graft gets sealed. I'll show you a small video on this. So this is how it gets harvested, gets cultured, and this is the defect preparation. And this is the matrix membrane that gets according to the defect size gets incorporated and gets sutured onto it. And this is how it should be sutured if it's in the trochlea. Opposite sutures first, and then diagonal, and then the rest. And then at the end of it gets incorporated into the defect, the ACI. So this is another picture of the same. This is Macy. So coming to the limitations, the survivorship of the hyaline-like tissue compared to the native cartilage is still unknown, and there is availability of ACI that it's the most important factor, and high cost of all these procedures, the two being a stage procedure, cannot be patient friendly, and there is longer delay in total maturation and return to sports. So this is an article by Gobi et al. He found that there were higher scores in BMAC group, and when compared with ACI, that is Macy, and the amount of defects that getting filled is 76% in Macy, but it's more 81% in BMAC, although negligible, but BMAC is more. This is PRP. Autologous PRP is defined as a platelet concentration of at least 200% of its peripheral concentration. So it can be produced by 3 different ways. One is blood filtration and platelet pheresis, and the second is centrifugation by single spinning method and centrifugation by double spinning method. So you have to know that the double spinning method will increase the amount of concentration, but so that it increases the concentration of the leukocytes as well. And so this PRP has all this PDGF, TGF beta, and FGF. And this also causes stimulation of the proliferation of mesenchymal stem cells, and also has anti-apoptotic and anti-inflammatory effects. So this is in Arthroscopy 2012, where they classified PRP, where this is called as a PAW classification by DeLong et al. P stands for the absolute number of platelets, and A stands for activation methods, and W is presence or absence of white cells. So the main defect limitation of this classification is they did not use the method to use to prepare the PRP. So next, in 2018, Harrison et al. Described this new classification where he classified based on the amount of leukocytes present. It could be either LPRP or RPRP, and based on whether it's activated or not. So 1 is without activation, 2 is activated, and 3 is frozen and thawed preparations. And based on the type of centrifugation, it's gravitational centrifugation, standard cell separators, or platelet pheresis. And they, based on the concentration as well, it's been classified as A, B, and C. So there is this is very important because there is a huge variation in literature that each study quotes their own method of preparation, and there is no standardized protocol to prepare PRP. These are some of the studies which, on comparison, this is how that's been nomenclatured. So 2B1, so 2 stands for standard cells activated, and B is platelet count of 900 to 2700, and 1 stands for gravitational centrifugation. So activation is by thrombin, and so this is how the nomenclature goes here. And again, red and L is the leukocyte and erythrocyte PRP. So yeah, here you can find that the PRP, there are all this positive is good outcomes in the study. And there was one study where PRP did not provide a superior clinical outcome compared to hyaluronic acid. And most of the studies where they used it for ONEs, in early ONEs, PRPs seem to have a good functional outcome. And this particular Korn et al. In 2011 found that there was longer efficacy of PRP rather than an viscosupplement injection. So this in Kaminsky et al. In 2018 also found there was increased propensity for meniscus repair, and even in chronic tears as well. So to conclude, some of the best outcomes of ACI can be seen in corneal defects in 2 to 12 centimeters square, and in younger age group. So there is increased complication in the first generation to MACI, and the return to sports is after 9 months, and BMAC offers good results whenever indicated. There is lack of standardization of preparation of PRP in the literature. Thank you, sir.
Thank you, Rahul. There'll be a lot of things overlapping between the next talk and this, so we'll have a discussion after the next talk. Praveen is not able to share, I guess. So until the time he shares the screen, Rahul, your talk well streamed. It was sad. You have to start with indications, contraindications, then the technique methodology comes, then the results come. So it was not initially itself, it was little haphazard and not well streamlined. You have to make sure it's well streamlined. And results wise, So indications, everything. There are so many procedures. So the algorithm, which is in the next talk, will give us when to do what procedure in a more streamlined way. And PRP is indication currently not for cartilage defects. We mainly do it for tendinopathies, tendon tears, muscle tears. But PRP is a good scaffold for a cartilage. So now some research is going on using PRP as a scaffold and add BMAC onto it, or ACI cells onto it, instead of using the fiber and glue. So that's the basic science research which is happening in India. In the CMC Vellore, they are working on this, where they have proven PRP is a good scaffold. And you had told that when there is a subchondral bone loss, it's a contraindication for ACI, correct?
So it's more than 6 millimeter, but later it can be done as a stage procedure where the bone loss can be addressed first, and the second stage ACI can be done.
No, they call it as a sandwich technique, where you place fill the bone with bone. Then they initially they have a cutoff of 7 mm, which I think is too much. So whatever bone loss is there, it has to be filled with bone. Bone has to be filled with bone. So bone graft, bone defect, and add a ACI on for the cartilage. That's called sandwich technique. But it can be done in single stage. Probably if we, I mean, while taking the graft, you can do that. Probably is the way they were described somewhere. And other option is Macy. Macy is scaffold, right? Mayo
sir.
region and certain scaffolds come with 3-layered scaffolds, which is for a subchondral bone also. So if for the area where there is subchondral bone loss, that thickness of that scaffold will be cut and used. So in that third generation ACI, you can still do subchondral bone filling with the scaffolds.
Yes, sir.
So Praveen has joined. So let Praveen continue.
Am I audible, sir?
Yeah, Praveen, go on.
Sorry, sir. There is some issue with my laptop, sir. Yes, sir. So I'll be speaking about some of the few recent advances with regards to cartilage defect management and the algorithm for cartilage defects. Yeah. So as you know, focal defects are fairly common, present in 36% of athletes and twice more so in general population. But most important point to note is that most of them are majorly asymptomatic. So any cartilage surgery, if attempted, only should be considered for symptomatic defects. So this is what I've been discussing for the past few weeks. So the classically tested and tried procedures for described procedures for cartilage defect include primarily marrow stimulation and microfracture subchondral drilling, or any allograft or autograft osteochondral transfers, and as just now discussed, autologous chondrocyte implantations. Apart from that, there are a few other novel techniques that are coming up. We'll just briefly look at each of them and then move on to the algorithm. So first thing is the microionized cartilage extracellular matrix. So which basically is used as an augment in marrow stimulation techniques. It basically contains desiccated acellular particulated cartilage allografts. So it is basically put in the area of marrow stimulation to enhance cartilage formation. If use can be used in conjunction with either a BMAC or PRP to augment the biological activity. So either can be done arthroscopically or through open, but arthroscopy is preferred in most places. The defect is prepared, marrow stimulation done, and prior to using this biocartilage, the defect should be thoroughly dried and the slurry is placed in the defect and sealed with the fibrin sealant. It should sets in 5 minutes and should be taken through a range of motion to ensure the fixation is stable. Very few results with good, few studies, only one study showing good results for the use in talus and distal tibia at 1 year follow-up. Another new modality being tried is the autologous matrix-induced chondrogenesis. This is basically containing the marrow stimulation effects within the defect. So in addition to marrow stimulation, layer is collagen or hyaluron-based membrane is placed on top of the defect. This just retaining the marrow elements, which this allows for a better differentiation and better cartilage formation. This is preferably done to a small arthrotomy, and the defect is templated and the patch is contracted in template, and should be mildly undersized and fixed to the bone using absorbed sutures of fibrin glue. This has been around for quite some time, and the good results shown at up to 5 years and 9 years follow-up. This is an example of how this is done. This is an initial cartilage defect, which is then prepared and marrow stimulation is done, following which hyaluron and collagen membrane is placed and secured with fibrin glue. BMAC just now, as discussed by Rahul sir, so it should be injected into the defect and secured with fibrin glue. If used with the previous technique, it should be, the membrane as such can be used with, soaked in the BMAC for 10 to 15 minutes and used. So possible sites, as we know, most commonly iliac crest or the distal femur and proximal tibia. If done arthroscopically, the notch is preferred. Prior to BMAC implantation, if there's a bone defect, it should be addressed. Prior bone graft should be done and can be secured with fibrin glue or a membrane. So the results with the BMAC have shown similar results with ACI and BMAC, and is definitely more superior to isolated marrow stimulation techniques. And just as discussed previously, most studies are conflicting results because there is no standardized procedure of preparation and the use of volume of BMAC being injected. Another new modality which is being considered is particulated juvenile allograft cartilage. So it's basically allograft cartilage from young donors. The idea is that it has more biological activity as compared to the adult chondrocytes and can be viable for up to 45 days. So this can be done a staged or a single procedure, open arthroscopic, depending on surgeon's choice. One packet of a commercially available device can cover a defect of up to 2 to 2.5 centimeter squares. So again, if there is a bone loss present, bone graft should be addressed. The bone graft defect should be less than 5 mm to the adjacent healthy subchondral bone. This can be either prepared outside or prepared into the defect and implanted as one unit and using a fibrin glue. And when used, should at least fill 50% of the depth of the defect, and usually recess 1 centimeter below so that it doesn't get dislodged in movements of the joint. Usually takes 10 minutes to set in, and there are no long-term results available regarding the same. Another variation of the same is the particulate autologous cartilage, where it is similar to juvenile allograft. Instead, autologous cartilage from the patient is used. So where this is similar to ACA, where 300 milligram of cartilage harvested without subchondral bone and prepared, minced into small pieces, and the choice of graft harvesting usually from the intercondylar notch. The defect is prepared, templated, and fibrin glue is placed onto the defect. Then the cartilage place is applied, then further secured on fiber glue and secured on the membrane. And further knee should be taken through movement to check for stability of the fixation. Again, fairly new modality, no long-term results available. Another technique is where viable cartilage allograft or conventional known as CARTIMAX, where it consists of 2 elements: allograft chondrocytes with an additional extracellular matrix to, again, with additional growth factors to augment the biology. Can be used to fill defects of up to 5 centimeters square, and has shelf life of 1 year. So initially the chondrocyte solution is first thawed, then the solution is then further mixed with extracellular matrix to form a putty. This sludge can be added to the defect and molded appropriately to fit in the defect. This is a main advantage of this. It is easily moldable, can give a good press fit into the device, into the defect intraoperatively, and doesn't need additional membrane or any fibrin glue to secure the fixation. Another new thing is the scaffolds. This is also just discussed. So it consists of a thin layer of hyaline cartilage on a microscopic layer of bone with multiple growth factors embedded into the scaffold. This also is perforated, which allows for better contouring and increased surface area for chondrocyte growth. Can be used in conjunction with marrow stimulation or BMAC to enhance biology. So the defect is prepared, templated, and the appropriate size scaffold is used. So point to be noted is the bone layer should be in approximately against the subchondral bone with direct opposition, and hence usually fixed with sutures or using fibrin glue. This is an example of a scaffold, how it should be used. After the graft is prepared, the defect is templated and secured onto the scaffold is templated and secured onto the defect. Another similar is argonite biphasic osteochondral scaffolds, which is still under trial. Technique is similar to osteochondral allograft transplantation. Coring device is used, and the scaffold is fixed with the press fit. Again, can be used with BMAC for enhancing biology. Another new modality being tried out is where allogenic umbilical cord mesenchymal stem cells as for enhancing biology. So it is primarily indicated for grade 4 cartilage defects. It is available as a 1.5 ml vial mixed with 1.5 ml solution of sodium hyaluronate solution, allowed to cure for 30 minutes. And then multiple drill holes are made into the defect site. And this solution is just implanted into the drill holes and covered with the membrane. This is again very recent. There's only one study published from Korea, with just 7 patients. And again, they also reported certain possible immunological side effects following the use of this technique with vague back pains and polyarthralgias and even elevated anti-thyroglobulin levels. So that's about the other recent advances with regards to cartilage defect management. So moving on to the algorithm. So as discussed at first, the aim of cartilage surgery is only to address symptomatic grade 3 and grade 4 defects. It should be attributable to the cause for patients' persistent pain, swelling, or any other functional limitations. As in, other causes should be ruled out. And in case of long-standing chronic cases, adequate trial of conservative management should be given before considering surgery. And most important factors to be considered include the appropriately conveying the patients what is the post-op rehab protocol, what is the expected length of recovery with the procedure being considered, and also the ultimate goals the patient can expect at the end of the recovery. And as with the other conditions, any concomitant pathologies, if present, like any instability or meniscal injury, should be identified and addressed in the prior or in the prior setting, or at least in the same setting. So what are the key determinant variables which influence the choice of treatment? So most important is the size of the defect, and followed by location of the defect. And more other important reason is element is the condition of the subchondral bone on the defect, and of course the patient's demands and expectations. So since subchondral bone defect is considered a very crucial element, so what constitutes a subchondral bone defect? Subchondral, I mean, when the subchondral bone considered deficient, it can be deficient if there is bone loss, like either due to trauma or osteochondritis dissecans, or if there is a significant extensive edema into the subchondral region in form of cysts, or if there is any previous surgery into subchondral bone, like either a previously attempted marrow stimulation or osteochondral transplantations. So this is the algorithm which is put forward depending on the size and condition of the subchondral bone. So as you can see, surgery should be considered only for grade 3 and grade 4 osteochondral lesions. And if primarily first looking at lesion with no defect with no subchondral lesion, this further should be categorized either a small to medium sized defect or a large sized defect. So as we can see, most of the described techniques, all of the described techniques can be used for a small to medium sized defect with no subchondral bone. And most of the new techniques under study are again confined to just this category to addressing cartilage defects with the intact subchondral bone. So as you can see, the classically described procedures like marrow stimulation, allograft transfer, autograft transfer, or allograft transfer, or ACI have shown a very high level of evidence and tested over time. Other techniques like journal allograft, AMIC, and BMAC are showing promising results, but again, long-term results are awaited. Other new techniques are because of the because they are very recent modalities, long-term results are not available, and efficacy and safety of these modalities for use is also questionable. So moving on to other large size defects, as you can
Praveen, you're not audible.
so am I audible, sir?
Yeah, yeah. I can see a lot of people coming in and going out. I think in internet connections because of the rains, some issue. Am I audible? Sir.
Sir, net is unstable in learning centers. Sir.
So by the time Praveen joins again, any doubts from fellows regarding these two talks? Anything you want to clear regarding ACI, BMAC, PRP, or cartilage defects? Please go ahead. In cartilage defects, as Praveen was mentioning in the initial part, there are various options, and all depends on whether what's the size of the defect, what's the depth, and patient profile. What's the age of the patient? What's the demand? Is it high demand, low demand, and the location? There are, I mean, you can categorize that as patient factors as a whole, and the lesion factors in the knee. So in the knee, you have to see where is it weight bearing, non-weight bearing, and then cost factors and time factors are also there. So
There is my screen visible now, sir?
yeah. Go on, Praveen.
Yes, sir. So I'm not sure where I got cut off, sir. So no, it's subcondylations. Okay. So as you can see, in lesions with the defect with the subcondylar bone lesions, marrow stimulation definitely will not be ideal, hence will need additional bony procedures in the form of either an autograft transfer or allograft transfer. So autograft transfer can be considered for defect of medium-sized defect up to 4 centimeters square, beyond which might lead to increased donor side morbidity. For a larger size defects, the preferred treatment of choice is osteochondral allografts when available. And if there is provision available, even ACI can be considered using sandwich technique, just as now described by Santosh sir, where a layer of bone grafting is laid to address the subchondral defect, following which the cartilage procedure is done to address the cartilage defect. So to further looking at the further key points to with each subcategory. So for a small defect without bone loss, bone marrow techniques are adequate, and almost all other cartilage techniques can also be attempted. So of the techniques available, since marrow stimulation is the least expensive and technically less demanding, it can be considered. But however, most studies have shown the marrow stimulation has shown good short-term results, but the results have been poorer with long-term follow-ups after 2 years. So it can be recommended only in a select population of acute, small, well-shouldered defects in the femoral condyles, and not for vague, diffusely multifocal defects. If the patient is a high demand, probably an osteochondral autograft can be considered over a marrow stimulation, since it has shown good results over long term. Again, when looking at patellar femoral defects, ACI has better results compared to marrow stimulation alone. And also in the setting of revisions, if there is a previously failed marrow stimulation, then there's increased chance of chondrocyte based failure of isolated chondrocyte based procedures. Hence, an additional osteochondral procedure should be like OAT or OCA can be considered based on size of the defect. In general, OCA is considered as a treatment of choice for revision, since you want to decrease the donor side morbidity when attempting in if we had to attempt in autologous transfer. And moving on to medium-sized defects without bone loss, other techniques other than marrow stimulation have shown good evidence with the long-term results. And in general, autologous transfer can be used over ACA because of the reduced cost, early mobilization, study showing early return to sports. Only problem with the OAT is cannot be considered larger defects because of donor side mobility. However, with patellar femoral defects, ACA and OCA seem to have better results as compared to autologous transfer, primarily being because of the variable morphology of the central patella, and since it might be difficult to counter the osteochondral allograft in the central patella and trochlea, where ACA is definitely more advantageous technically as compared to OAT. If all these are not available, then a juvenile allograft and BMAC can be considered, but they're again at the early stages and showed good results. These naturally have the advantages of ACA in preserving the subchondral bone, and can also be used in all knee compartments. Moving on to large size defects without bone loss. So again, because of the size, an allograft should be considered, or ACA or ACA should be considered. Good results are shown with the use of with both OCA and ACA with respect to femoral condyles. So it's primarily matter of surgeon's preference. And if with the multifocal defects and patellar femoral defects, ACA is shown to be better, technically more easy, technically little more easier as compared to OCA. And also the use of osteochondral allografts and multifocal defects using a Snowman technique, where the grafts are placed overlapping each other, have shown poor results in long-term follow-ups. So probably ACA can be considered with respect to patellar femoral defects. And also ACA has better results compared to osteochondral allografts in bipolar defects in both articular surfaces. And other only if both this model, if ACI or OCA is not available, joint allograft and BMAC can be considered. So coming on to small size and medium defects with bone loss, or both any bone. So as with any case with the bone loss and osteochondral, the graft is preferred. Both OAT and OCA is approved procedures. So primary choice based on the size and location. So an OAT is ideal for small defects up to 2 to 4 centimeter up to medium size defects. OAT can be considered, beyond which OCA should be considered. And with respect to patellofemoral joint, in case of with bone loss, as just discussed, an OCA can be considered over an OAT, primarily because an OCA can have a graft from a similar location from the patella and allows for easier contouring and also reduces donor side mobility. And also ACA can also be considered if there is, but if used, the initial bone defect should be addressed by a sandwich technique, initial bone grafting, following which an ACA should be done. So coming to even larger defects, the primary treatment is again, it's similar to treating medium-sized defects of bone loss, where an OCA is the allograft of the treatment of choice for all locations, and ACA or ACA is considered only if allograft is not available, and if considered should be used as a sandwich technique, since isolated cell-based techniques may not be as effective if there is a significant subchondral bone loss. So this is another algorithm suggesting a treatment modalities based on the age and based on the physical demands of the patient. So as we can see, most of up to this chart is exactly the same as in the previous algorithm, but like to highlight the last part of the chart where you can see for a high demand patient, even for a small size lesion, microfracture, marrow stimulation may not be ideal and will require any cell-based or bone-based procedure like either OATS or ACA should be done. And similarly, however, with respect to patellofemoral defects, ACA seems to be preferred over OATS because of the easy contourability and technically, or even osteochondral allografts are preferred over OATS because of, since they can be contoured to the defect better. So coming to the influence of age on these procedures, there's a recent study published in OJSM in 2021, where they have evaluated 21 studies comparing cartilage precision. The age criteria taken is greater than 40 years and less than 40 years. Most of it is a case report. So their key conclusion was that there is no adequate evidence to support cartilage repair in the middle age as with the current literature. If anything is considered a marrow-based or even cell-based techniques are actually shown inferior results with increasing age. Only bone-based techniques have like OATS or OCA have been unaffected by age, but then again the use of bone-based techniques in middle-aged person is again should be balanced against the demands and the needs of the patient for such an extensive procedure. And coming to the return to sports following cartilage surgeries, this is an initial study by Pesca et al. Published in AJSM 2015, where they evaluated 130 athletes who underwent ACI. So important finding is that most of the patients had given up high impact and pivoting sports. Return to competitive sports was only as low as 31%. And more recent meta-analysis been Casta by Chris et al. With 2,509 athletes, where they showed that overall return to sport was 76%. However, in this paper, they have not mentioned the prior level of sporting for the athletes and the level they which return to. Just as looking at the data, you can seems that overall oats as better better and faster return compared to OCA and microfractures. However, it is confirmed by the fact that both oats and microfractures are done for relatively smaller defects as compared to OCA. So the real data regarding return to sports following cartilage procedure is still under study. So just like to ask my colleagues to volunteer what they think would be the best treatment option in such a scenario, where there's a 25-year-old active footballer, basically high demand young man with a 3 centimeter grade 3 defect in the medial femoral cartilage without any subchondral bone loss. Anyone?
It's a high demand individual with a medium sized defect. The first choice should be osteochondral autologous transfer, oats, and we can, second choice should be an ACI probably.
Yeah, since it is a defect is less than 4 centimeter, and because of its high demand, bony procedure can be considered against the isolated marrow stimulation. So a similar situation, the 50-year-old male with a low demand chronic pain, first presentation, how would does that change anything? Chip.
It's a low demand, small defect. We can try any conservative like microfracture, conservative or of operation by microfractures.
Yeah, so as discussed, in long-standing cases, probably a adequate trial of conservative should be done prior to trying any surgical procedures. And if surgical procedure is attempted, probably because of just 2 centimeter lesion, microstimulation, marrow stimulation should be adequate. Next case scenario, an active athlete with a larger defect, more than 4 centimeters in the patella with subchondral loss.
It might be due to the size of the defect. It may osteochondral allograft can be used, since there is a subchondral bone loss also present.
Yeah.
So because it involves a patellofemoral joint, I feel ACI or MACI is the better choice.
Yeah. So if the cost is not an impairing factor and if facilities are available, both can be considered. Only if ACI is considered an additional procedure, the bone graft should be addressed prior. That is a sandwich technique where the bone graft is, the subchondral defect is addressed prior to implanting ACI. So the take-home message is cartilage surgery should be considered and attempted only in symptomatic cartilage defects. The treatment plan is multifactorial, and the plan is to be formulated individually based on case-to-case basis, primarily considering the patient demands, patient complaints for follow-up, and the patient's expectations. And also, as with any procedure, the surgeon's expertise in performing the procedure and the added costs. Most important factors to be other factors technically should be considered apart from the age and demand is the size of the defect and the condition of the subchondral bone, and also the location of the defect. So of the described procedures, marrow stimulation can be considered and to be restricted to only small to medium sized defects with subchondral bone, and that too only in low demand individuals. For higher demand individuals with larger defects, cell-based or cell-based technique like ACI or a bone-based technique, either oats or OCA should be considered. Most surgeons seem to prefer the use of ACI for patellofemoral joint and OATS and or OCA for femoral context, depending on size of the defect. Thank you, sir.
Thank you, Praveen. Good session where I think you conveyed the message because all of them answered for the scenarios quite well. Only one question which I would ask again other fellows. If the size of the defect was 1.5 into 1.5 centimeters, is it a small defect, medium defect, or large defect? Anybody?
It's a small defect, sir. Less than 2 centimeters is small defect, sir.
Anybody else?
It depends whether it's in the patella or in
No, just the size. Is it small, medium, or large?
the small.
Small, sir.
Okay. Whatever it's written in the literature is the area, not the dimensions. So now, what size is the defect?
Medium.
Medium. Yeah.
Medium.
So
Medium.
whatever
Medium.
you've learned is the area of the defect. So 2 centimeters means, I mean, it's a 2-dimensional thing, right? And so if it's 3-dimensional, you need 3 values. So whatever is in the literature is the area of the defect. So 2.5, sometimes they say 3 centimeters. So the cutoff will be around 1.8 into 1.8. If it's or 1.5 into 1.5 means it's already, how much is it?
220, sir. 220.
So yeah, so it's almost medium-sized defect. So whatever you mention, if it's 2 into 2, it's a 4 centimeter defect area.
Yes.
Actually, it should be as a centimeter square, but whatever is there is the area of the defect, and size actually is the area which they mention. Ideally, it should be mentioned as centimeter square, but all over the literature it is like that. So dimensions sometimes even in dimension size, length and breadth also matters. For example, if it is a antero-posterior defect in the femoral condyle, if it's a long 5 centimeters antero-posteriorly, and mediolaterally you get just 6 mm widthwise, it's actually a good defect. Sometimes such furrow kind of defect happens with the loose body locking, where the loose body gets locked and it scrapes out the entire cartilage. Those defects are ideal defects to have, rather than medial lateral. From medial to lateral long and anterior to posterior short, those defects are difficult to reconstruct. The loading with pattern is different. For anteroposterior long defects, OATS is easy to do, but medial lateral larger defects, OATS is difficult to get the congruity. So even in size, there is a slight variations which you might need to consider. Even for medium size or large defects, you might still do if it's a narrow one. So when you're mentioning about size, it's you have to be careful about how you interpret it when you're doing the surgery. And any other points to discuss regarding PRP? The PRP, leukocyte-rich PRP, in literature, they say it's sometimes effective, but the incidence of the reactions, pain is higher. So there is no clear consensus of when to use leukocyte-rich, when to use leukocyte-poor. But there was an article which mentioned it, but there's no clear consensus of when to use what. We generally use leukocyte-poor because chance of pain, post-op pain, post-injection pain is slightly less. Am I right, Rahul? I'm not sure if any newer updates are there on PRP. Rahul?
Yes, sir. It will increase the inflammation. It will cause pain, sir. The leukocytes.
Okay. Sir, any more points, sir?
No, just questions rather. No, the BMAC results are as good as ACI. Did I hear that right? And why not use BMAC instead of ACI? It's also cheaper, one sitting. When exactly you cannot
exactly
use BMAC?
No, ACI is superior to BMAC. The long-term results of ACI or BMAC, we don't have long-term good clinical studies actually. And ACI is definitely superior in large defects than BMAC. But ACI does not restore hyaline cartilage, but that's the best next to osteochondral transfer. Next best. When they go to the larger defect, the problem is getting good contour. So that's the only problem with OATS. But ACI histopathologically is superior to BMAX. So when you're going towards a larger size defect, ACI definitely scores higher. Histopathologically superior.
Now, how good is the Arthrex BMAC, the cell count and all that? Do you monitor? And
This Arthrex one is a automated one. The machine has a cell counter. So with that, it separates the layers. But the other ones are manual. They visually see which are the layers and aspirate manually, which has a higher chance of errors. So Arthrex Angel, that machine is slightly foolproof compared with the manual methods.
no, who gives the manual one?
So that Tricell
Oh, okay.
and Harvest.
Mhm.
So this Angel machine has a cell counter, so it separates as per the cell inside the machine itself, the layers. So which is actually better, and it's a closed system, no manual handling of and transferring involved. So more sterility. So that's why we prefer that.
Yeah, thank you.
Any doubts from fellows before we go on to the next talk? If not, we'll move on to the next talk. Praveen, you can unshare yourself.
Thank you, sir.
Now, something about, sorry, just one question about fibrin glue. You said PRP may be better than fibrin glue. Then why not using it? Even the last case, I think you used fibrin glue, didn't you?
Yes, sir. Technically, for using a PRP, we have to take out thrombin and we have to prepare it manually. The technical aspects, we do not have it currently. And using it in the dual syringe, it's not yet possible to use it. It's in the laboratory stage. CMC Vellore, they are doing PRP using it as scaffold. But
Okay,
dual
okay.
syringe, we cannot. We have not used it clinically yet. Sir. Whatever I told was laboratory phase.
Right, thank you.
Santosh Yuvraj here.
Correct.
All these procedures will need a long-term follow. And how frequently do you go for a second look orthoscopy or repeat MRI? So with this healing of this ACI or chondral procedures, OATS. So what's your experience in your clinical practice?
So we've never done a second look arthroscopy, but we've done our biopsy here. But we've done MRI follow-up studies. There's a scoring called MOCART scoring for MRI. That's the standard scoring system which they use to measure how good is the filling of the defect and how is the quality of the defect and how is the bridging area. That's more important. The bridging between the normal cartilage and this cartilage. If that is done, happens and that is the scoring, then that's how we score it. We've done a series for the ACI, and we've all these athletes who come up, they ask for MRI after, but the minimum time is 1 year, but ideal to do it at 2 years follow-up MRI, because MRI will show complete healing only at 2 years. This is our experience, but literature-wise, biopsy. Ramchandra have done a couple of cases, only 2-3 cases. But in Europe, they've done biopsies. That's why histopathologically, ACI is superior to BMAC based on their studies. And long-term outcomes are good with the ACI compared with all the cellular procedures. But osteochondral transfer is the best. Only thing is getting a good contour. That's why what we do here is this hybrid technique, trying to name it as a nut in jelly technique, where we fill the majority of the defect with osteochondral transfer with good spacing so that we get a good contour as much as possible, and add a cellular procedure like BMAC or ACI, where we get a base of a hyaline cartilage and osteochondral bone, and fill the remaining areas and the superior contouring with the cellular procedure, cell gel. So we've not got good number of MRIs with them, but clinical outcomes of all these procedures have been very good. And if there is a loose fragment, we try to fix them. We do not discard any of the loose fragments which are salvageable. So getting the native osteochondral piece over there has been proven quite an advantage here, and that's the study which we are trying to do with EPEN. In literature, they or in general practice, nobody really advises to fix them or keep the piece there. Whenever they see, they throw it out and look at reconstructing them. So, what we are trying to say, reconstruct with the fragment and add anything else, whatever is there for the remaining, so that your size of the defect reduces. A medium-sized defect becomes a small defect, or a large defect becomes a medium-sized defect. So that's what we are trying to say with EPEN's paper.
Okay, Santosh. Thank you.
We can go on to the next Plasti talk.
Good morning, sir. Is my screen visible, sir?
Yes, Umar.
Yes, sir. So today's topic is on patellar resurfacing. So my talk would cover the history, designs, patellofemoral kinematics, principles of resurfacing, surgical technique, resurfacing strategies, complications, and some registry data. Starting with history and evolution, Bruce and Wambley in 1942 described the patella as somewhat mysterious bone, and initially the patellectomy was preferred. Insal et al. Reported 4 different prosthetic models used in early 1970s, none of which made any provision to accommodate the patella. Even the earliest duocondylar prostheses had no provision for patella. Then in 1969, Lothar Hanslick of Berlin reported the use of a modified version of McKeever patellar prosthesis, which is made of a high-density polyethylene. And then the Munster TKA combined a femoral mold arthroplasty with a tibial polyethylene disc and a 3-pegged polyethylene patellar component with the surface geometry described as carina shaped. And this lead to a modern-day prosthesis. Then Charles Townley cruciate retaining anatomic total knee became the first total knee replacement system, which allowed for optional resurfacing of patella with a cone-shaped polyethylene patellar component, which was first implanted in 1973. Then asymmetric anatomic patellar component of porous coated anatomic TKA system was designed by Hungerford and Kenna for use without cement and first implanted in 1980. By rotating the patella up to this component up to 180 degrees, it allowed to serve as a right or left side implant. And then the retropatellar surface geometry provided a high level of conformity with femoral component, especially in early flexion range. So various patellar component designs are available, which are dome, offset dome shape, cone, Gaussian shape, then cylindrical and anatomical shape. The most commonly used is a dome shape, with its principal advantage being its ability to allow for flexion and rotation to occur in various planes and without binding of the implant against the femoral component. In a native knee, the patellar contact area varies with various degrees of knee flexion. It starts the bifurcation of patellar femoral contact occurs beyond 100 degrees of knee flexion And then the odd facet of patella engages with medial femoral condyle between 125 to 135 degrees of knee flexion. Then post resurfacing, the contact area changes. Initially, there is a point contact in extension and early flexion because of limited conformity between the implant and the femoral flange. Later, it becomes line contact in mid flexion at 30 to 60 degrees due to increasing conformity. And then finally, there is bifurcation of contact area beyond 90 degrees. Coming to kinematics, the patella increases the efficacy of quadriceps muscle by 50% by functioning as a fulcrum, and thus anteriorly displacing the line of pull and increasing the momentum of quadriceps muscle in relation to center of rotation of the knee. And it also facilitates the improved distribution of patellar femoral reaction force through an increased contact area during flexion. And in addition, the patella centralizes the divergent pull from all four muscles of the quadriceps and thus transmitting these forces to patellar tendon, thus preventing dislocation. So various studies have been done on quantifying the patellofemoral reaction force. So as per these studies, the lowest patellofemoral reaction force occurs in activities such as level walking, but it increases in activities such as stair ascent and highest in stair descent, isometric extension activities, squatting and kicking. Then the stress contouring occurs in unresurfaced patella. If it is left unresurfaced, there is a gradual adaptation of retropatellar surface on subchondral bone plate to the trochlear shape. And this remodeling process is not displayed in radiographs at least for 2 years after implantation. Then a study on contact stresses in unresurfaced patella. In unresurfaced patella, the peak contact stress and contact area remained almost at the level of the native knee. But following the patellar resurfacing, the patellofemoral contact stress rose beyond the yield strength of ultra-high molecular polyethylene with an average increase of 200%, whereas the patellofemoral contact area decreased on average by 60%. Thus, the option of leaving the patella without a prosthetic component is better in cases in which the patella is not severely worn. Coming to principles of patellofemoral joint resurfacing. First, there must be restoration of physiological patellofemoral spacing, that is the composite thickness. Then the recreation of retropatellar high point through correct placement of the patellar implant. Then restoration of patellofemoral relationship, that is the joint level. Then the restoration of rotational alignment of femoral and
Sukumar, your voice is not audible, Sukumar. We lost your voice. Dr. Sukumar? Sukumar, your voice is not audible. Please check your net connection, Sukumar.
Yes, I'm calling him, sir.
Sir, is my screen visible now, sir?
Yes, Sukumar.
Okay, sir. Principles of patellofemoral joint resurfacing. First, the restoration of physiological patellofemoral spacing, that is the composite thickness. Second is the recreation of retropatellar high point through correct placement of the patellar implant. And then the restoration of patellofemoral relationship, that is a joint level. And restoration of rotational alignment of femoral and tibial components. And finally, the balancing of patellofemoral soft tissues. First, the femoral component anteroposterior positioning. The recreation of physiological patellofemoral spacing requires a bone resection according to implant thickness. Overstuffing of the patellofemoral joint through under resection of patella or the distal femur is to be avoided because it increases the patellar strain and it may exacerbate minor degrees of patellar tilt or maltracking, particularly during knee flexion. Then the internal rotation of femoral component will affect the patellar tracking by lateralizing the direction of pull of extensor mechanism, and it further creates excessive valgus alignment of lower leg inflection. Then some measures to improve patellar tracking. Lateral positioning of the patellar implant will tighten the lateral retinacular structures and it may provoke the lateral patellar tilt and subluxation. Moderate medialization of the patellar component in conjunction with slight external rotation and lateralization of the femoral component will balance the medial and lateral retinaculum, which will assist in centralizing the extensor mechanism and thus improving the patellar tracking. Next, the tibial component positioning. Internal rotation of tibia or femur component will increase the Q angle and then the lateral force vector, and it may lead to patellar maltracking and instability. And then the combined internal rotation of both components will exacerbate the effect on patella. This is a study on component rotation and anterior knee pain after total knee arthroplasty. It found that in patients suffering from anterior knee pain after TKA, the tibial component measured on average 6.2 degrees of internal rotation more compared to 0.4 degrees in control group. This is another study. It assesses the 30 knee arthroplasties affected by patellar tracking abnormalities by relating the level of lateralized patellar tracking to the degree of combined internal rotation of femur and tibia. The combined internal rotation of 1 to 4 degrees, it resulted in lateral patellar tracking and tilt. 3 to 8 degrees resulted in a patellar subluxation, and 7 to 17 degrees resulted in frank patellar dislocation. So according to INSAL, the center of the anterior portion of the tibial base plate should be aligned with the tibial crest, which is equivalent to the medial third of tibial tubercle. This is the ideal positioning of rotation of tibial component. Then the axial limb alignment. The key is to establish a physiological leg alignment, which varies between 5 to 7 degrees of anatomical valgus. Any increase in valgus beyond 7 degrees will again increase the Q angle and therefore contribute to patellar maltracking. Long-term follow-up studies have also shown that the prosthetic survival is not compromised if the leg alignment is restored within 2.4 to 7 degrees of anatomical valgus. Coming to surgical technique, the patellar preparation, the patellar bone should be resected parallel to its anterior surface to create a uniformly thick remnant. And then the overall patellar thickness should be established first using a caliper. Usually it's between 22 to 24 mm. And it has to be subtracted from the manufacturer's patellar component thickness. For example, in Smith & Nephew, it was 9 mm. So if you get a 22 mm thickness of the native patella, you have to reduce the minus 9 mm, and which we will get a 13 mm. So the remainder equals the target dimension of the bony patellar remnant following resection. The remnant must be 13 mm. The care should be taken to preserve a minimum of at least 12 mm of patellar bone, and the composite height of the patella should not exceed the pre-resection levels. Two techniques can be followed, either a freehand resection or guide directed. First is a freehand resection. This is popular with experienced surgeons who use attachments of patellar and quadriceps tendon as reference points to guide the patellar resection. The cut level should stay approximately 1 to 2 mm above the tendon insertion and needs to be coplanar to prevent the rocking and produce close coaptation between the implant and bone surface. Next is using a resection guide. They include a stylus to allow for presetting the level of cut, and although the resection guide produces a smooth and even cut surface, they are position dependent and rely on surgeon's ability to apply the guide at the appropriate depth and obliquity. Next, the placement. The central ridge of the patella separating the medial and lateral facets is not equidistant between the medial and lateral margins of the patella. Symmetrical dome implanted in the middle of the cut surface of the patella will again lateralize the articular surface of the patella, increasing the Q angle and lead to patellar subluxation. So because of this asymmetrical geometry, an anatomic component can be placed centrally, whereas a dome variant requires to be positioned off-center towards the medial patellar border. Next, the correct alignment is critical for unimpeded patellar tracking, particularly using an asymmetric anatomical implant. The sizing spoon is aligned perpendicular to the patellar tendon and placed in slight superolateral position on the everted retropatellar surface. When the patella is reduced, the spoon handle needs to attain perpendicularity with the trochlear groove and should be approximately 3 degrees off parallel to the joint line. That is in external rotation to enhance the proximal patellar capture. Then sometimes overzealous medialization has been shown to leave excessive bone on the exposed lateral patellar facet, causing impingement, erosion, and pain. So the recommended medializing patella is not more than 2.5 mm. Thus, it has been recommended to chamfer the patellar rim to reduce the risk of bone impingement. Next, thickness. When resurfacing, it is important to recreate the physiological thickness. The average patellar height in men and women ranges between 22 to 24. Some authors have recommended keeping the composite height of the patella slightly below the level of native patella by 1 to 2 mm. And studies on this study on effects of resection thickness on mechanics of resurface patella. Author has defined the critical thickness of residual patellar bone at not less than 11 mm, below which the patellar surface strain increases exponentially and there is high risk of patellar fracture. So when patellar composite thickness exceeds the preoperative values, it creates an overstuffing on patellofemoral joint with subsequent increase in retinacular tension, anterior patellar strain, and patellar reaction force, leading to patellar tilt and subluxation. Thus, the overall flexion is also reduced and the risk of patellar component failure and fracture risk is also increased. Next, joint line. The maintenance of joint line and the patellar height is shown to be an important factor in recreating normal kinematics, especially important when using a posterior cruciate retaining arthroplasty design, because the ligaments must be balanced properly to achieve a satisfactory range of motion. Raising or lowering the joint line will create a secondary patellar baha or alta, respectively. In cases of patellar baha, the patellofemoral compressive forces will be increased during early knee flexion and overall range of motion is often compromised. And if the joint line elevation is excessive, the patella will become prone to impinge on the anterior margin of the tibial articular surface. Then coming to lateral release, Scott's rule of no thumb is widely used in assessment of patellar tracking. The test is performed before the closure of medial capsule. If the patella tracks well throughout the full flexion arc without the surgeon's thumb holding the patella located in the trochlear groove, no release is necessary. If the patella subluxes without counteracting pressure from the thumb, the retinaculum should be released in staged fashion until the patella is stabilized. But this technique has been criticized by some who believe that it may overestimate the need for a lateral release. Other techniques such as towel clip test and one stitch or a single suture test have also been described, claiming advantages, but they are also the variations of the same test. Brayard has described the kissing rule, implying that if in deep flexion, the medial surface of the patella does not touch the medial condyle of the femoral component, a lateral retinacular release is indicated. Then tourniquet release is thought to provide more realistic appreciation of patellar cracking, and it has shown to reduce the number of lateral releases by 31%. Coming then the technique of lateral release, the incision is made approximately 1 to 2 centimeter lateral to the patellar margin in an inside-out fashion, dividing the synovium, capsule, and retinacular fibers up to the subcutaneous fat. Then the release is performed in stages with the clinician assessing the patellar tracking regularly and therefore tailoring the amount of tissue released to the requirements. The identification and protection of the lateral superior genicular artery prior to performing a lateral retinacular release will help in preserving the blood supply of the patella and thereby reducing the risk of AVN. Then patelloplasty. It is recommended if the clinician decides not to resurface the patella. The procedure is essentially designed to recreate the patella shape and surface configuration similar to the native patella. It involves the removal of any marginal osteophytes from the periphery of patella, and in case of significant deformation, a lateral facetectomy. Then the surrounding patellar meniscus and excessive synovial tissue are generally excised to avoid a soft tissue impingement. Some surgeons promote circumferential thermocoagulation, which is thought to create a level of sensory denervation in an attempt to combat occurrence of anterior knee pain after surgery. Then resurfacing strategies. 3 strategies are followed: either to always resurface, never to resurface, or selectively resurface. First is always resurface. Clinician who prefer always resurface claim the reduction in incidence of postoperative anterior knee pain, avoidance of secondary resurfacing, higher patient satisfaction, better overall function, a low complication rate, and then the procedure is relatively inexpensive and not time consuming. Some have also argued that addition of patellar implant assists in centralizing the extensor mechanism and thereby compensating for minor degrees of patellar maltracking. Then to proponents of always to resurface, the articulation between the cartilage and metal is considered unphysiologic, and prolonged exposure to high compressive forces is believed to cause cartilage erosion. The prevalence of patellofemoral complications following primary resurfacing has decreased significantly and currently remains at around 4 to 5% when using contemporary implant designs. Then strategy of never resurfacing. Clinician in support of patellar retention argue that the clinical results between patients with or without resurfacing are similar, and resurfacing therefore represents an unnecessary step in performing a TK. Other claims include conservation of patellar bone, reduced likelihood of osteonecrosis, more physiological kinematics, ability to withstand high patellofemoral forces, especially in young and more active patients, without the concern of prosthetic wear, failure, and ease of resurfacing in case of anterior knee pain. Then next evolved is the concept of selective resurfacing. It is not simply based on resurfacing patella presenting with significant retropatellar cartilage degeneration. But it aims to identify individuals who will have an improved clinical outcome with patellar resurfacing, while at the same time avoiding potential complications associated with unnecessary resurfacing. It was first advocated by Scott and Rayleigh in 1980. The retention of patella is favored in patients below the age of 65 years who are not affected by rheumatoid or any crystalline disease, whose retropatellar cartilage is reasonably well preserved, who have no significant anatomical abnormality. For example, the adequate patellofemoral congruence and normally shaped patella of adequate thickness, and patients with normal patellar mechanics with central patellar tracking and who do not suffer localized anterior knee pain. The decision to resurface is generally based on the presence of preoperative patellar femoral symptoms, that is a localized anterior knee pain, radiological evidence of patellar femoral arthritis, the intraoperative assessment of the state of the retropatellar cartilage and patellar tracking. Next is some complications of patellar resurfacing include patellar fracture, polyethylene fracture, polyethylene wear, then component dissociation and component loosening. So patellofemoral problems occur in up to 1/3 of all revisions performed within the 10 to 15 years. Data from Swedish registry suggests that patients with primary patellar resurfacing are 3 times more likely to undergo revision when compared with patients with in whom the patella was retained. And out of all revision performed in patients with resurfaced patella, 17% were performed for patellar dislocation, 13% for implant loosening, 6% for implant wear, and 2.5% for patellar fracture. Seeing patellar fracture in brief, the fractures of patella following resurfacing have been attributed to AVN secondary to disturbance of patellar blood supply. Other potential causes are technical errors and patient demographics and implant design. Then the overall risk of patellar fracture following resurfacing is 0.2 to 5.2%. Conservative management should be considered whenever possible because of the risk of complication is high, and most authors support prolonged immobilization in extension followed by gradual mobilization in a hinged brace. Next complication is patellar instability and dislocation. Surgical improprieties during the patellar resurfacing are common reasons for this complication. It include residual valgus limb malalignment, patella alta, increase interrotation of components, medial translation of the femoral component, and asymmetric patellar resection, lateral placement of patellar button, excessive thickness of the patellar composite, and improper soft tissue balancing, and failure to perform lateral release when required. Then patellar implant loosening. It is reported to occur in 0.6 to 4.8% of the cases. The commonest cause being the obesity, followed by lateral release, elevated joint line, and flexion beyond 100 degrees. Other factors include poor remaining bone stock, asymmetric patellar resection, small fixation pegs, inadequate implant fixation, patellar maltracking secondary to component malalignment, osteonecrosis, and osteolysis. Next, implant wear. The level of wear damage appears to increase with the patient's weight, post-operative range of movement, and length of the time the patellar component has been in place. Some registry data. For the past 10 years, on collecting the registry data from various countries, it has been shown that the highest percentage of TK with patellar surfacing has been done in countries like USA, Canada, Denmark, and Belgium, with to 80 to 70%, with the lowest being in Italy, Norway, and Sweden. Some studies have been done on bilateral comparative trials with one side of the knee patella being resurfaced. On comparing these studies, a meta-analysis of these studies, it revealed a total of 299 patients, 5 years. The satisfaction and the resurfaced side was favored in 35% of all patients. The non-resurfaced side was favored in 18%, and 47% of the patients expressed no preference for either. So the take-home message is decision-making and surgical technique for resurfacing is equally as important as other steps of TK. And compared to always resurface or never resurface, selective resurfacing is a better option. And selective resurfacing attempts to identify the individuals who are likely to benefit from resurfacing and at the same time avoid the potential complications associated with unnecessary additions of patellar component. Thank you, sir.
You covered all the important aspects in patellar resurfacing, starting from the design evolution, and the principle behind the patellar resurfacing, and how one should address the intraoperative issues when you are planning for a patellar resurfacing. And the registry, even the meta-analysis and systematic review shows, and definitely the patellar resurfacing group shows a better outcome with related to anterior knee pain, painful crepitus, overall satisfaction when compared to a non-resurfacing group. But it depends on how good the surgeon in executing this patellar resurfacing. That is very important. That Pranavat used to say, the most difficult part in total knee replacement is doing a good resurfacing of the patella, because it should be accurately balanced. That's very important, and the cut surface should be it should be very precise, because it is basically a 1 mm balancing of the 1 mm balancing of the patella, actually, from when you are getting a thickness. So that is very important. But starting from the pre-op evaluation and which patient will be benefited with the patellar resurfacing, you should assess clinically, radiological assessment, intraoperative. So based on that, you have to decide. So which patient? So that's what I'm in favor of selective resurfacing, and we did a study in that. We found that the resurfacing group will be benefited when the score of patellofemoral score combined with the radiological parameter and with the intraoperative cartilage assessment. We combine all these three things and we mocked a score, and the score of less than 40 or more than 40, it depends on that, we'll decide. And it has both objective and subjective scores in the patellofemoral score. Basically, it's a HSS score. So those groups are less than 40, with those who have a poor score less than 40, those score people, we did a selective resurfacing, and those people are really benefited in the long-term outcome. And compared to the design, and the minimum thickness which is available is the 9 mm or 8.5 mm. Only in the biomed group, the available patellar thickness was 6.5, but it is not available in the market currently. So minimum thickness of the patella currently available is a 9 mm thickness. So, but for that, at least we need a residual thickness of 12 mm after resecting the cartilage and subchondral bone. But the majority of the time, we are dealing with a female, short, and obese individuals. Our residual thickness usually comes to 11 or 12 minimum. So, and the patient, especially with elderly individuals with osteoporotic bone, so you should be very careful. You should not make a prone to develop a fracture, intraoperative or iatrogenic fracture. So you should be very careful in doing the patellar resurfacing. You can execute in both the way, whether you can use a zig or you can use a freehand technique. But freehand technique, but exactly what you mentioned is you need a more experience by doing a repeated patellar resurfacing, because unless otherwise, if you make a proper cut, and it should be a parallel, and thickness should be measured in all 4 zones: superior, inferior, medial, and lateral. It should be uniformly thick. For example, if you are targeting for a 13 mm, it should be 13 mm everywhere. I suppose if the lateral side is 14, the medial is 12, it will go for a patellar tilting, and there will be a patellar maltracking. So always recheck with your patellar button, measure the thickness, and check with the freehand technique, no thumb technique, intraoperatively before going for implantation. So that is very important. And yesterday also, we had one case, and the residual the thickness of the patella was 21, and we don't want to resurface those patella, the size of 21, especially female and short individuals. But after the final tourniquet release, and when we checked for the tracking, and there was a clunk sound, especially there are different anatomical variations in the patella, where this median facet of the patella, which it's placed, some patella of the patients are not same as like other patella. Like, for example, if the median facet is more prominent and the medial facet is small, in those patients, they have a high tendency to go and get stuck into the box. They're basically in the PS knee. So those patients, they'll give a click sound while going for a deflection and coming to the extension. In those patients, we have to resurface. So we executed after that, after checking their tracking. So after the resurfacing, we'll be able to get the centralized patella. So in those patients are really beneficial. So that's what it should be, a more of like a selective resurfacing of the patella is really beneficial, especially in our Indian population, because we do face a lot of short and obese patients. So that is very important. The complication wise, in my experience in the past 7 to 8 years, there is no much complication related to the patellar resurfacing compared to the non-resurfacing. But one patient, we had a fracture following a fall with a non-resurfacing patella. We managed with the implantless suture technique. So that patient has improved reasonably post outcome following the surgery. Otherwise, the both outcomes are reasonably good. The few indications in my practice, number one is inflammatory pathology, go for a resurfacing. Patient with valgus knee, go for a resurfacing. And number three, the patient with severe patellofemoral arthritis, especially male patients with thick patella, for example, more than 25. After total knee arthroplasty implantation, you must have noticed there is a thick patella that tracking, so that will give a grinding sound with the crepitus with the anterior knee pain. So those patients are really not happy. So those patients will consider for a resurfacing. Yeah, thank you.
One doubt, for the small patellas where we are hesitant to cut the bone because already the patellas are thin. How are the outcomes? Would it be worthwhile to ask companies to manufacture smaller thickness patellar resurfacing implants, or these patients anyway do well because of small patella?
Definitely, if you have option of having a 6.5 or 7 mm, the minimum recommendation from the FDA is the poly thickness should be at least 6 mm. So at least we need a thickness to withstand the compressive force. So more than 6.5 to 7 mm of patella. But definitely do well. But only the one company they provided previously with 6.5, but others they manufactured as per the other recommendations from the US, all the 8 mm minimum, 8.5 or 9 mm. But leaving the small patella, the outcome wise, it's good only, because it is very risky when you're taking this patella. Unless otherwise we're very meticulous. Sometimes I go for a overstuffing of the patella by 1 mm rather than going for a understuffing. And because of the 12, if you're going for 11, I'm definitely increasing the risk of that fracture of that patella. So really, I'm very much concerned when you are dealing with a small patella. I will try to avoid the resurfacing. Rather than going for a resurfacing of the patella in those situations. But definitely we should consider manufacturing the small patella. It definitely will be beneficial for our Indian set of population.
Do we have any studies of a series of how many patients which we ideally require a resurfacing we are not able to do because of the size of the patella? Can we do a series and come out with evidence and suggest that as a paper or presentation?
Yeah, definitely we can do it, Santosh. It's actually we do measure for all the components, because almost now we have 300 patients. We have an intraoperative anthropometric measurement, and in that the first part we submitted for IGO, and in that part we are not included the patella. We measured
separate paper.
That separate paper. We measured other anthropometric dimensions of the femur and tibia, but we do document for all the patients intraoperative thickness. So we have a data, almost 300 patients. Definitely we can pull the data and we can segregate and we can identify those things.
Yeah, you can mention as Asian patients.
Yes, exactly. Yeah.
Okay. Thank you.
Thank you.
So any doubts, any questions? If not, shall we end the meeting already 8:50?
Yeah, please. 9 o'clock then. Yeah, 8:40. Thank you.
Yeah, thank you.